Okay, I think we should go ahead and get started, and we can expect a few more to join over the next few minutes. But if they missed my introductory remarks, it's not as important as missing the main content. So I'd like to welcome all of you to, I don't recall which number this is in this series of webinars in our Southern California Regional Dissemination, Implementation, and Improvement Science series. We are hoping to move to a monthly schedule next year, so watch for emails with schedule of new speakers. We have a special guest this time rather than a local speaker. The date happened to coincide with the two-week visit from Dr. Nicola Carey. He's on the faculty at the University of Surrey in the United Kingdom, visiting to attend the NIH Dissemination Implementation Conference in a couple of weeks, spending a couple of weeks here in Los Angeles, with colleagues at UCLA, the VA, Kaiser, Cedars. There actually are some remaining slots available in her schedule for phone meetings or in person. So those of you who are interested in further discussing the focus of the webinar, please reach out to me, Brian Mittman, to see what we arrange. But let me go ahead and slide the phone over and turn the mic to Dr. Carey, who will speak, as the title indicates, about research that she's done, in addition to some policy and practice considerations on non-physician prescribing as a quality improvement strategy. Thank you.
Hi, good morning, afternoon, everybody. Thanks very much, Brian, for that kind introduction. I'm really delighted to be able to talk about our work over in the UK about non-physician prescribing. Traditionally, it's actually called non-medical prescribing, so if I use that term, it actually just means the same thing. So this is just a slide from the actual aerial view of our campus. So if you could just move to the next slide, please. Also, it's just really for people who don't know where the University of Surrey is. We're a half hour southwest of London. And, because we have very good train links to London, and these are just some sites of the campus. The top right is where I work. It's called the Duke of Kent Building. It is in the shape of the Titanic, apparently. So it's just an interesting little factoid. And there's just pictures from around the campus. Okay, so next slide, please. So in the UK, non-medical prescribing or non-physician prescribing is very incremental over the last 20 years. Initially, it was brought in to improve access to medicines, improve flexibility of service provision, and improve efficiency without compromising safety. And next point, please. Of healthcare professional skills. Next slide, please. Although there's actually quite a lot of definitions of prescribing in the UK, what she termed prescribing is the act of determining what medication the patient should have and the correct dose and duration of treatment. And in the UK, the legal right to issue a prescription, for medication rather than supplying or dispensing medicines. That is actually quite different to other countries around the world. Next slide, please. So, in addition to the UK, there's quite a lot of different countries. I know in America you have prescribing that's linked to advanced clinical practice, and this is really an overview of the different countries and the states, different various sort of levels of prescribing that we have. A fundamental difference between the UK and all the other countries in the world that it's not linked to any sort of advanced practice. It's regulated as such, although people have to undergo further training. It's not at an advanced level. Next slide, please. So, as I said, the non-medical prescribing in the UK has been very incremental. And it started off in 1999 with what we call community practitioner prescribers. And they're probably the equivalent of what you would call public health nurses in the US. There's approximately between 36 to 40,000 of those. They take a very short course, it's 3 days of learning, and they can prescribe a very limited formulary, which are mainly appliances, dressings, and pharmacy and general sales medicines, such as things like paracetamol and ibuprofen for temperature and things like that. Now, the body of the work that we've looked at is this second group, which are called nurse-independent supplementary prescribers, and these first level registered nurse, and there's around over 30,000 of them. These nurses, their training is much more extensive than the community practitioner prescribers. Have to undergo 27 days of face-to-face education or online learning, plus 90 hours of clinical practice, supervised clinical practice. They also have numerous assessments, and they have to undertake a pharmacology exam, a practical examination, a literacy exam, and develop a competency framework from then which they prescribe. Now, in addition to nurses, we also have other healthcare professionals who are able to prescribe. We also have pharmacists, dietitists, physiotherapists, optometrists, and radiographers. So, please. So, just in the UK, these independent supplementary prescribers, it is actually two different qualifications, although you come out with a dual qualification after the training course. Independent prescribers are able to assess, diagnose, and prescribe independently any licensed or unlicensed drug, except some controlled drugs for the treatment of addiction. As prescribers is a form of dependent prescribing, where the initial diagnosis is made by doctors, and then you have to agree a clinical management plan, which is by a doctor, patient, and the supplementary prescriber, which details the medicines that can be prescribed within their area of competence. So those are discrete forms of prescribing, and so let's just bear in mind as we progress. Slide, please. So although there's lots of benefits and lots of anticipated benefits, there are some challenges and concerns that have arisen over the last few years. One of those concerns related to the low use of prescribing once qualified. So, all the evidence suggested that these community practitioner prescribers weren't using their qualification that much. And there was a concern that nurse-independent supplementary prescribers would follow that path. But what we found is that it is actually used very well, and there's been numerous surveys, and they've all consistently come back with very high levels of prescribing of the qualification. And reasons for not prescribing is when people move to a role where it's not required. Our latest research in the area continues to show that there is low use amongst these community practitioner prescribers, those who work in mental health settings, and also pharmacists. Also an issue of overconfidence, that when nurses use structured guidance and formulary, it helps promote adoption of independent prescribing, particularly by mental health nursing. Please. Again. Just to give some context to where all this information comes from, ago we were involved in a study which was in one large area, the east of England. So typically we surveyed all non-medical prescribers in this area, including nurses, doctors, pharmacists, anybody really who's registered as a prescriber. You can just, next slide please. What we found here, as you can see, is that the majority of prescribers working in primary care for acute trust, so they would be our hospital settings, general practice. So primary care is sort of different to general practice. So primary care would be where nurses work, and general practice would be where our practice nurses and nurse practitioners work directly with the GP. And have shown over the last few years, although the number is still very high in primary care, the number of those who are taking the qualification in secondary care is actually increasing significantly. So the nurses in acute settings are increasingly taking up this qualification. Found as well that there's quite a lot of variation in prescribing frequency. Now, one of the original concerns when prescribing was introduced, where the formulary was opened up to nurses, was nurses would be going prescribing all over the shop, and there would be very high rates of prescribing. But what actually shows here is that using independent or supplementary prescribing, the number of items per week is actually quite moderate, between 11 and 20. And part of that can be explained by the fact With our activities as nursing, although we have this prescribing qualification, we actually use it in many other ways, just to literally write a prescription. So we might alter or correct a medication, we might make a recommendation, and all these things are quite difficult to collect information on. So, and people don't necessarily recognise that they are making a prescribing decision. And the other thing is that the government has really been interested in the actual number of items prescribed, because that's something they can count through prescriptions that are issued. And the other issue with that is that those that work in a hospital setting don't actually issue prescriptions that can be counted. So this information is sort of limited. So it's just from information in primary care. But for the purposes of this slide, this is what the nurses themselves are reporting. Next slide, please. Okay, so again, this is a more recent survey of people who are undertaking the course, where we surveyed students as they were sort of starting off on their prescribing training. This is between 2012 and 2014. And as you can see here, the number here in secondary care is actually 44%, whereas before it was around 20%. What I found here that the number of conditions that people intend to prescribe for is quite high, between 1 and 16. The number of items of prescriptions remains quite static. It's somewhere between up to 1 and 20. That's again sort of confirming that it's sort of like a consistent of what people are doing. And now, supplementary prescribing is when it was originally introduced, the formulary was restricted, so nurses weren't able to prescribe any medicine for any condition. So they introduced this sort of stopgap, which was supplementary prescribing. The problem with this is that it's obviously dependent on having a doctor available to sign off the clinical management plan. And so nurses have now got the right where they can use independent prescribing. Some still require newly qualified prescribers to use supplementary prescribing the first year, and particularly those in the mental health setting. So there seems to be particular concerns around that. In our own research over time is that actually the use of supplementary prescribing is really, really reduced, and those who did use it were confined by legislation, local policy, or the need to prescribe these controlled drugs that they were allowed to prescribe for. So, as it was youth prescribing once qualified, it does seem to take nurses quite a while to sort of go their initial concerns over prescribing. There seems to be a high level of anxiety associated with that. And that should be a repeat slide, so apologies for that. So I've got a repeat slide, so just the next slide, please. What we do is, and this is consistent over the last 10, 15 years, that frequency of prescribing is linked to the level of support and care setting and prior experience that these nurses and healthcare have. So we've also defined on a consistent basis is that fewer items prescribed per week by community practitioner prescribers, mental health nurses and pharmacists. The more recent systematic review comparing the number and range of medications showed mixed results depending on the condition and type of medication that was prescribed. Please. So in the survey that we conducted in 2012, there was a wide variety of areas that nurses are prescribing for. So I think what it, perspective, what it shows is that of the work is done for minor ailments and pain and wound care and skin conditions, and that's been consistent right from the beginning. And of these areas of care where nurses have traditionally had a lot of experience. Slide, please. Next slide. So thinking about some of the benefits of prescribing, I mean, I've been very fortunate to be involved in a number of studies over the last 10 or so years, which have specifically been conducted to evaluate what's actually been happening in practice. Particularly, we've looked at diabetes and dermatology, and we've done a lot of case study work where we've actually, done a range of prescription methods, stakeholders and patients, sort of exploring everyone's perspective. Next slide, please. Consistent in what we found across our research, but also in other research that's been done in this area, is that there's a consistent reporting that there is faster access to medicines for patients, which is ultimately what it was all about. Everyone thinks it makes better use of nurses and doctors' time. So before, nurses and doctors would nurses would have to wait to get the prescription signed by the doctor, or they would have to interrupt the doctor to get the prescription signed. All that is eliminated. And I think particularly in hospital settings where doctors are not necessarily on site all the time, nurses work in outpatient clinics, that's a massive improvement for the nurses and for the patients. All the evidence shows so far that care provided is equivalent to that provided by doctors. There hasn't really been any concern, there hasn't been anything that's demonstrated that the care is a poorer standard to doctors. Of course, that was one of the initial concerns that doctors had. And the fact that that has been equivalent has alleviated a lot of doctors' anxieties. So to start off with, doctors were anxious and had a number of concerns. Over time, it has been alleviated, and doctors have been a lot more receptive to it. It wasn't needed as high patient satisfaction service. High patient satisfaction. Patients consistently are happy with the service when nurses are able to prescribe medicines. And our research as well is that prescribing allows services to be streamlined. So, whereas before, if a nurse wanted to provide a clinic in the community, they would have to run that in tandem with the doctor, so the doctor was able to sign the prescription. It offered the opportunities for nurses to be able to provide those clinics independently without that doctor input on, and that really is quite a significant development in the way that nurses use the qualification. There's also nurses report higher levels of autonomy and improved job satisfaction at a time where there's a turnover of staff within the National Health Service. I think that's a pretty good thing to find out. Next slide, please. So these are the findings from our qualitative work where we've interviewed nurses. And it's just some examples of what the nurses feel. I think some of the concerns that the medical profession had around nurses and access to the whole formulary was that, as I said, that they would prescribe willy-nilly and they would try to become mini doctors. But impression that we've all had from our perspective is that we want to be maxi nurses rather than mini doctors. And this is just a good example of this. I like to make the decisions with the patients. So we do a lot of working through products to find the one they like and the one they're going to use and the one that they work and the one that works. I'm here to do that work with them, whereas maybe a doctor wouldn't. I think it helps because it really reduces the problem with eczema if you get on a regime like that. And then a pain nurse, it's just fantastic now. You can say to the patients, just bear with me, I'll be a few minutes, we'll get this sorted out and we can get on top of your pain. Whereas before I didn't feel confident enough to be able to say that because I knew all the frustrations I was going to have to get that job done. Slide, please. And some feedback quotes from nurses who prescribe for patients with respiratory conditions. And more recent study that was just conducted a couple of years ago. The biggest thing for patients is the delay in getting the prescriptions, especially when they're acutely unwell. People not prescribers have to come back at the end of the day to write a letter on the computer, fax it over to the GP, etc. And then the prescription gets generated, and sometimes it takes up to two days. Whereas if I've gone to see them, I can prescribe it there and then. And 2 days in the lifespan of a patient with COPD who's having an acute exacerbation, that's quite a significant reduction and a significant improvement in access to medicine. Please. So as our travels, we've interviewed different groups of patients, and they also find nurse prescribing very acceptable. And something that I maybe should have said, that all this information that I'm talking about relates to nurse prescribing is up until very recently there hadn't been any commissioned studies that looked at the other groups of prescribers, so this is why it's all about nurses. So patients report able to ask questions and solve problems. That look at a more holistic approach to care. Health and lifestyle issues are considered. That the patient treatment is tailored to them as a person rather than to the condition. And they're better able to understand the condition and the treatment, and as a result, better able to manage the condition and treatment. Patients report them are confident in the treatment, they feel increasingly satisfied, and have an overall increased sense of well-being. So they're all very, very positive. Please. And these examples from some interviews with patients that we've done. So diabetes patients. Usually I see the nurse and I have to see the doctor. If the nurse can prescribe anything I need, then it's going to cut a lot of time. And in a lot of these patients, if they have to, if the doctor's not there, then they might have to come back to the GP practice or wherever the healthcare organisation is to collect the prescription. And, you know, if people are working and things like that, then it just eats into their own time. And also there's the travel time and the cost of that if people have to take time out of work. And here's another patient talking. It's as though it's been tailored for you rather than, I mean, the last time I asked for a prescription at my GP, he just spoke to the computer. And we can all relate to that. Well, I can, in the US. Next slide, please. A lot of gaps in the evidence. If you can just click, please, and click again. So, sorry, I'll go back. Yeah. So, nurses, doctors, and other key stakeholders report benefits to nurse prescribing with significant gaps in the evidence. Little research evidence of the benefit in terms of measurable patient outcomes. So what we have so far is what patients say, but we found that very difficult to measure so far. And there's been a lack of any sort of economic analysis. But what, as I'm sure some of you are familiar with, is that we have, there's been a systematic review, nurse-led care, which some of them have included nurse prescribing. What we found is that what they found is that there are few differences between nurses and doctors in clinical outcomes, and the patients are equally satisfied or more satisfied with nurse care, and quality care indicators are equal or higher. But again, that's not based on any of the work, based on our special group of prescribers and literature reviews, and obviously some of that work is quite old, from 2004. Please. So one of the things that doctors and other healthcare professionals had is, do non-medical prescribers have the necessary training and experience to prescribe, able to trust the nurse prescriber, and a non-nurse prescriber aware of their own limitations and to refer to the doctor when in doubt. Now, all the evidence suggests is that nurses do have the necessary training, but we get to this issue over trust. Doctors feel like they trust nurses that they know, but feel more anxious considering the wider population of nurses. So the nurses that have come through quite soon in the process to come through as prescribers have a well-established relationship with their doctor. The doctor's been very supportive. In situations where that relationship hasn't been so embedded, it's become a little bit more problematic. An example from a study we did a few years ago. This is a doctor talking about a nurse in secondary care. I was very anxious about high-flying, ambitious people who do their nursing and really do their prescribing, because whilst they may be able, what they have not had is experience, and that is essential. So these are just some of the concerns that the doctors have. Next slide, please. One of the concerns that patients have had is that the a presumption, correctly so, that nurses or non-medical prescribers have had the appropriate training. The proof that non-medical prescribers are experienced in the area of practice. They've raised concerns whether the nurses can assess and diagnose to the same level as a doctor, and are aware of their own limitations and able to refer to a doctor when in doubt. Very similar to the fact we had from the doctor. I've seen other nurses, and I certainly wouldn't feel confident with them prescribing. But if you've got a nurse that's fully clued up and takes their time to learn, they're good, if not better, than the doctor. So about the individual, that seems to be very important in the success of this initiative. Right. The non-medical prescribing survey that we did a year or so ago, although the top anticipated benefits that nurses reported were to reduce waiting time for patients and reduce waiting time for the doctor and to provide more holistic care, there is a number of concerns around litigation, about confidence and conflict of, regarding misunderstanding between the patients. But again, we know from previous work is that the use of structured guidance promotes adoption of independent prescribing and can help overcome these top anticipated concerns. Slide, please. So our journey through the introduction of nurse prescribing, we've undertaken quite a lot of observations of consultations in practice, and we've done various types of analysis and interpretation of those results. And what we've found consistently in our work and the work by Latter is that they are inconsistent in some areas, particularly around asking patients about their use of herbal and over-the-counter medications. Consistent in explaining the risks and benefits and potential side effects of treatment. And there's some concerns around improving history taking and assessment and diagnosis. Slide, please. So which shows assessment of communication skills by nurses that were undertaking dermatology conditions. So as you can see, the listening and understanding was rated very highly, but on the bottom line, the information on side effects is given. That's obviously not so highly scored. As I say, that is consistent in every study that's been done. So that is something that we are mindful of. Please. Sort of a note of caution on that slide is that a high number of consultations observed in the studies did involve repeat prescribing for long-term conditions such as diabetes or dermatology, where side effects could have been discussed in the initial consultation. Medications may have been initiated by a doctor some time ago. However, a high level of disagreement between our experts over the extent to which these aspects of care were correctly conducted. And our assessors, we had a range of assessors, some of whom were medical consultants and others were consultant nurses. Here is don't presume that these issues have already been discussed, and that you probably should be checking on that at some stage. As well is that initial nurse prescribing and non-medical prescribing was introduced, there was a lot of issues around a lack of clinical governance. So that's just really our sort of procedures that support safe practice. And in a survey that we conducted in 2012, we asked about specific areas of clinical governance and the extent to which they were in place. And it was that although the and other healthcare professionals did have agreed scopes of practice, they did issues in accessing their own prescribing data, and there seemed to be a lack of acknowledgement about the need to audit their own clinical practice. There seemed to be a belief that it was someone else's job, that they didn't really need to be taking that on board. They weren't actually really checking what they were doing in practice as they went through. Slide, please. Challenges that we've come across more recently is that what we found is that as over time, non-medical prescribers have become more involved in complex decision making, and they're prescribing in very specialist areas, and quite often for very complex drugs. And they're prescribing for patients with multiple morbidities. Two-thirds of nurse prescribers are prescribing for complex conditions in their main area of practice. 58% did report concerns about their ability to do that to the best very well. We have a problem in the UK around access to patient records and computer-generated prescriptions, particularly for nurses who work in the community or who are based as community nurses like district nurses or health visitors, or specialist nurses who do clinics in the community. None of the systems are linked up. It's all very fragmented. So they don't have access to full patient records, and that's problematic when people are trying to provide the best care to patients. Next slide, please. So more recently, the whole process of prescribing in the UK has been very incremental. And fairly recently, physiotherapists and podiatrists were only able to prescribe using substitute prescribing. As you've noticed right at the beginning, the number of people who are prescribed in those two professional groups is very, very small. And part of the reason for that was because of the limitations that supplementary prescribing created for them. So in response to that, the Department of Health is forward ahead and to have extended prescribing rights in 2013. Physios and podiatrists now have independent prescribing rights. So they can act, they have access to the whole formulary, and they can prescribe in their area of competence. And because this is quite a significant change, the Department of Health has funded some work where we're evaluating it as it's being introduced. So this is a current study which is looking at independent prescribing by physios and podiatrists in England. Next slide, please. Next slide. This study, which is ongoing at the moment, is designed to evaluate the effectiveness and efficiency of independent prescribing. Now, the main difference between this study and all the other studies that I've mentioned is that the Department of Health are very prescriptive about what they actually wanted us to evaluate. And they wanted a lot for their money. So next slide, please. This is a 2-year study, which is in 3 phases. We've completed a literature review of what's happening in the area of prescribing for physios and podiatrists. We're conducting a survey as people come through the training course, beginning and at the end of the course. We're looking at document evidence that they have around service specifications. And we're also undertaking case studies where we're comparing people that are physio and podiatry independent prescribers, and we've matched them with people who aren't. Identify any differences in process or outcomes. Looking at this in medical management activities and barriers and facilitated care, and also trying to identify, what, if any, differences there is in the cost. So, our area, when this is the bulk of the project, which is ongoing at the moment, with 14 case sites with podiatrists and 8 physiotherapists, and we a multitude of data collection methods. We have completed 8 sites and 6 are ongoing, and these are just the various methods that we're using. Very, very preliminary assessment of the first 4 sites. What is actually, there is quite a significant difference between levels of satisfaction in the patients in the case sites between those that are prescribers and those that aren't. And we're looking forward to looking at that in more detail once we've completed the data collection. And the next slide are just some articles, and the next one as well. Just filter on.
Great, very much. So I wondered how you were going to get through 40-plus slides in the allotted time, but you said you could, and you did. I think I'll look for all of us. So if you could open up the mics for a Q&A, let me go ahead and start with the first question while others are joining. And again, thank you for the presentation. The broader issue that this is a part of, as I understand things, is what sometimes is called task shifting, the idea that we use division of labor kinds of concepts from management theory and reassign certain tasks and responsibilities to other members of the care team, allow clinicians to practice at the top of their license, develop a highly efficient division of labor, and so on. My question is whether there's some broad principles that either you used in this body of research or are deriving that would allow us to apply these kinds of ideas and study other forms of task shifting in behavioral health, for example, and other ways of making better use of the available clinician expertise and staff that we have to, in the case of the U.S. with health reform, care for a larger group of patients.
Well, I thought what was fundamental to the body, well, to the sort of incremental thing was that there was a large review done by Dr. June Crown in the early 90s, and then a second review. So to start off with, the practitioner prescribers, these district nurses and health visitors, were the only ones that could prescribe, and the very detailed evaluation of that. And based on the success of that, they then to introduce legislation to open up to other groups of nurses. Now, to start off with, it was very controlled. District nurses and health visitors in the UK have a specific registration, so it was linked to that registration. So you had to undertake special training to be a district nurse or health visitor. Then you had to do this course to be able to prescribe the medicines. And well, it sort of comes on tide of
on the 15th, I never suddenly received that there's going to be a new program that's launched by the...
We're getting some background noise. I don't know if it's a question or someone who should be on mute.
Okay, so I forgot what I was saying now then. So
in terms of the regulatory process and
it came on the back of all the changes to the European Working Time Directive. So up until that point, it had been a bit of a free for all for doctors working in the UK, and those restricted hours. So there was a massive gap, and obviously, with like all the organisation of the NHS in the late 90s, in the Blair government, it was about releasing potential to become more flexible and offering more flexible services in more diverse ways. So it was almost like all the government policies supported it, and at the same time the evidence was becoming that nurses weren't going to go here and go around killing loads of patients. I think that the very initial evaluation was probably fundamental to that. So the Department of Health invested in that right at the beginning, and it's still looking to extend it into different professional groups even more.
Similar kinds of research guidance?
Yeah, I think so, yeah.
So well, that's the way that we should be doing things in the States, and often do not, sometimes, but not as much as we should. So questions, comments from participants, please. And the chat function is live. Ibrahim Arturo, if that's another option for folks to submit questions or comments.
We're monitoring it, but we don't have any questions.
Okay. So I'll list, but let me give another few seconds of silence for anyone field to pose any questions. So one of my questions is whether you are developing from this work, and in some ways I suppose it's similar to my first question about sort of generalizability and general lessons. Is there a set of research questions, evaluation questions, and types of studies that ideally would be conducted both to guide the initial decision making, also provide ongoing guidance for any refinement as far as rules and restrictions on is and not within scope of practice, or how to improve care surrounding these changes?
With this current project, that's exactly what they're interested in. They're trying to see what, if any, of the issues are, what the issues that arises that seems to prevent people taking the course. Have to have, as part of the 90 hours of supervised practice, a designated medical practitioner. Now, for nurses, because they work quite closely for doctors, for most of them, that's not too hard to manage. But for these more diffuse groups like dietitians and physiotherapists and pharmacists, that's become quite problematic. So one of the things they want to evaluate is the extent to which they feel that these medical supervisors actually fulfill their role, or is it just piecemeal? And that's the bone of contention about the support that people do get through the course. One of the issues that they haven't addressed is people don't get reimbursed for providing support to people through the course, and there is a reluctance on the part of doctors to provide support, especially not directly employed with them. So, pharmacist or a pediatrician or something, and you want to access a doctor who's not directly involved in your service, that can be quite difficult. In cases, people have ended up having to pay extra money to get that supervision. So there's a little bit of a gap in the sort of thinking on that. One of the other issues that they're particularly interested in is the cost-benefit thing. So our study is the first one from all the national evaluations that has got this economic component. But one of the problems with that, and one of the limitations of the evidence base, is lack of economic data, because it's just very, very difficult to collect. Because once people on these roles of prescribers, their job actually changes quite significantly, so it's then difficult to find a comparator. So it's not like at the point where people have become a prescriber, it's actually too late to actually collect the transition from start to end. So you need to capture people before they even step onto the course. And as we all know, a lot of evidence it tends to be based on randomized control trials, and that's just going to be very difficult to achieve with this group of people. And I think that if there was more evidence of that nature, there would be more support and funding to support people through the course.
For some kind of step wedge design or other designs that would allow for at least some comparisons?
Brian, we have two questions on the chat, so whenever Dr. Carey is done answering to that question,
I'm sure there is, but we haven't found a solution to how to manage it. Because, as we've been talking about, the way that people work is very different, and so it's very difficult to get groups of people who are doing exactly the same job, because the way that nurses work, they sort of make the job bespoke to themselves. So that's difficult. But it's something that needs to be addressed.
And those differences, that heterogeneity, would be even more significant in the States, given the complexity of our system. Okay, Ibrahima, those are chat submitted questions, or someone on the line?
Chat submitting questions.
Okay. Go ahead.
Yeah. So the first one is: are there types of patients, specific conditions for which prescribing by non-physicians is better or best suited?
I don't think there is. I think nurses used to, on non-physician prescribing, using it across a multitude of service provisions. So from all kinds of inputs, all types of services, it's very, very eclectic. So whilst the majority of people are in primary care, it's a very, very diverse population that they're serving. So you could have nurses working, we have in the UK, I don't think you have that here, called walk-in centres, where basically are like immediate care centres. So you can basically walk in and expect to be seen within 2 hours for minor ailments or minor injuries. So nurses in that setting are prescribers, and literally anything that comes through the door. You have nurses that work in life care, like palliative care. You have nurses that work in drug and alcohol therapy, intensive care. You also have nurses that work as what we call night nurse practitioners, where basically they take on the role of the medical registrar. They're actually on the same rota system. So basically they're prescribing across a myriad of stuff. So it's very, 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 very diverse. So I think there is a specific condition for the patient.
All right. The second question is, in the U.S., I would expect pushback from traditional providers, parentheses, turf protection, to this kind of task shifting. Did the UK encounter that? If so, how was it dealt with? And are there any suggestions for the U.S.? Hello.
So
explain.
Translating some of the Americanisms, I think the general idea is, especially from the physician community, pushback to the idea that they're, low trained, to use a term that sometimes we hear, clinicians be given privileges that are traditionally reserved for the more highly trained clinicians, and that's been a problem. If I could add to the question, in the states, there are different state level regulations in some states where there have been expansion of prescribing privileges to other types of clinicians, other disciplines. There has been a fair amount of pushback from some of the medical associations. Is that an issue in the UK as well?
I don't think it is, because in the UK everyone's trying to get rid of work. I think that might have been what they thought. But I know that in in Australia they have a similar reimbursement system where where everything is linked to advanced practice. Nurses who prescribe in general practice, it's not reimbursed. So I think that's what you're saying. I think some of it is around the funding, but in the UK, the reluctance, the time it has waned. Some areas of medical, some areas of medicine were less reluctant, so reluctant than others, and one of those areas of reluctance was mental health. And I think another area of reluctance that's ongoing is in cancer therapy, chemotherapy, because it's very, very complex. Although there's no reason why they can't. It's a risk management situation.
That a somewhat simple or perhaps even simplistic analysis is, if a group of physicians are paid on a salary basis in a system like Kaiser and others, and they feel that they do have too much work and would like to give work, and there are no fears at all about for their services, that offloading some responsibilities to other disciplines would be to their benefit.
Yeah.
If on the other hand, we're in a fee-for-service situation and physicians are trying to keep control over as much work as possible, they wouldn't be quite as interested.
Yeah.
The U.S. system is much more heterogeneous, and we have a much broader range of physician employment and payment mechanisms, whereas in the UK, physicians for the most part are salaried, or they're Okay, so that might explain some of those differences.
Yeah, I'm sure it's here as well. One of the issues in the UK is that because the way people are admitted to hospital and the patients that are admitted are very much more complex. Mm-hmm. So they take up much more as consultant time. So they have to offload some of, they just don't have the capacity to be able to deal with everything in the way that they might want to. So.
Sure. Okay. Other questions, again, by chat or those online? Is on the line involved in similar studies within the U.S.?
No, we haven't looked at the all the literature from the U.S. It's actually very difficult to find out what's actually happened in the U.S. with less prescribing or whatever prescribing. And up until a few years ago, there was the American Association of Advanced Nurse Practitioners, and they were doing a biannual. That seems to have dropped off, and it's probably all due to finance, I would say. But these for America, because it's linked to advanced practice, nurses have had all this additional training and now working at a different level. If I think of the nurses that come through on our course, don't definitely work at an advanced level. So there is a fine line. Some might ever prescribe one drug because they're working in a very, very specialist area, and that's fine because they're only ever going to be doing that. But unfortunately, the regulation aspect in the UK, they've got on hold, so it's not really up for discussion just now. So.
Yeah, I don't know this area at all in the States, but I would hope that there has been and is now even more interest in research activity to understand state policies, the determinants of different policies, given the importance of this in the context of health reform, and the fact that the professions are not growing as rapidly as new forms of coverage and new nations demanding service, and this kind of task shifting is obviously one solution. So understanding the patterns in the U.S. and what are some of the key factors, what are the problems, and how to ensure that the policies that are established avoid the point safety issues that you mentioned and maximize the improved outcomes and efficiency. It's like an important area. Yeah. Questions, comments? A few minutes left, but there's no reason for us to use all of that time, especially for those who haven't had a chance to get lunch. Arturo, is there an evaluation form that will be posted on WebEx, or do you send it via email after the fact?
Let me post it right now, so I'm going to just start it right now. And people who are logged in, you will see on your screen the goal. Let me just start the goal.
So for you all to complete the evaluation, as I said, we're looking to double the frequency of sessions during the next year, given growth. I am sure that there are open slots during next year, so we encourage those of you interested in presenting to contact one of us. Meantime, as I said, Dr. Carey is in town for the next 10 days or so. If anyone is interested in follow-up, please contact me. Otherwise, I'd like to thank you again for the presentation and stimulating discussion.